Actually, we have shifted one session from Hall B to Hall A, and therefore it won't be the last session in Hall A. So we have another session from Hall B. I would like to invite Dr. Sunetra Mondal to speak on biosimilar insulin, reliable answer for Indian patients. I welcome you, ma'am. She is the Assistant Professor, Department of Endocrinology at NRS Hospital, Medical College and Hospital, Consultant Endocrinologist at Health World Hospitals, Durgapur. She received the Yuva Ratna Award in 2023 for Best Research in Private Capacity. She was also awarded by Endocrine Society of India in 2019 and received the A.V. Gandhi Award for Excellence in Endocrinology. I welcome Dr. Sunetra Mondal, ma'am. To chair this particular session, I would like to invite a very senior physician, Dr. Nirmalla Chakraborty, sir. He is a senior physician with special interest in nephrology and diabetes. I welcome you, sir, as the chairperson. I request Dr. Chakraborty to kindly introduce Dr. Sunetra Mondal.
Good afternoon. We are nearly at the end of our academic session. This is going to be a very interesting topic because biosimilar insulins are now coming up in a big way. And I think the 2-3 points we need to understand. One is, of course, whether they are equipotent as far as efficacy is concerned with the originator. That is number one. What is the chance of immunogenicity? That is, I think, is very, very important. And third, of course, like any other drug, the cost. In a third world country like ours, we have to think of cost as well. So these are the 3 points which come to my mind. We are all using originator, we are all using biosimilars. So how you differentiate these two and how reliable the biosimilars are is the topic. So I'll request Dr. Sunetra, the floor is all yours.
Thank you so much, sir. Good afternoon, everybody, and I'm very thankful to the organizers, Dr. Mridul Bera and Dr. Shah, for inviting me here. So my topic is on biosimilar insulins, whether they provide a reliable answer for Indian patients. And I thank my chairperson for asking those questions and setting the stage. So to try to find an answer to this, I start with 2 cases. A 56-year-old shopkeeper, type 2 diabetes, already on multiple OADs, still HbA1c uncontrolled at 9.5%, and I have plans to start him on basal insulin. So nowadays, along with history and clinical examination, another unwritten psychological attribute about every patient that I try to keep at the back of my mind is whether the patient trusts the doctor more or Google more. So thankfully, I mostly practice in tier 2 cities and suburban areas. So there we have more of doctor trusting patients than Google trusting patients. So this patient was doctor trusting patients, and he clearly discussed his affordability issues with me. Next is this patient, a 68-year-old gentleman who has recently retired from work, having type 2 diabetes for several years, already on basal bolus regimen with innovator glargine and pre-meal regular insulin boluses, still HbA1c uncontrolled at 8.9%. And this particular gentleman trusted Google more than the doctor. So of course, one thing is clear, both of these patients unfortunately belong to the vast majority of patients with diabetes in India who have not reached the target HbA1c. And of course, both of them need insulin, no doubts about that. We discuss a lot about barriers to insulin therapy, the patient reluctance, fear of injections, fear of hypoglycemia, barriers on the part of the provider due to clinical inertia, fear of the lack of time to explain. And what we sometimes forget discussing is, of course, the cost of therapy, and India sort of is high up on the list of countries with very high out-of-pocket monthly diabetes costs because most patients are uninsured. And when biosimilars came as a remedy to these affordability issues, truly speaking, they are sort of very new in the history of insulin development in the late 2000s. Now, looking at the definition of biosimilars, several global societies have given different definitions, but certain points are the same. First, highly similar. Highly similar to what? An already licensed reference product. No clinically meaningful differences. Now, differences with regards to what? This is what the different societies differ, but mostly it is about quality, safety, and effectiveness. When we talk about biosimilars, a lot of other terms also start playing at the back of our minds: generics, interchangeable, follow-on insulin. So trying to figure out what each of these means. So biologic products, as we all know, they are large and complex molecules produced recombinantly in living system like a microorganisms or in cell lines. Reference products are FDA approved biological agents, and originator product means when this reference product gets a brand name to it. Biosimilar, now this biosimilar, as I discussed, is highly similar to these reference products, and interchangeable is a biosimilar that has more evidences in its favor in that they have undergone a switch study, which means there have been studies which have shown that switching back and forth between the biosimilar and the innovator molecule does not cause any additional amount of risk or loss of efficacy. Follow-on product are all the copies of these biological products which have been approved by the FDA, and these follow-on products have been called by several names in different countries like biocomparable, subsequent entry biologicals or ACB, and of course follow-ons. Now biosimilars and the innovator molecules, both of them of course have to undergo a lot of testing before they come into the market. Only thing is that the pyramids are opposite for the innovator molecule and the biosimilars. So for the innovator molecules, clinical studies, the vast amount of investment is for the clinical studies, large number of patients, multiple countries. But when it comes to biosimilars, most of the investment is for the physicochemical and biological characterization studies to show they are highly similar to the innovator molecules. Clinical trials are much smaller, and so much of patients are not needed in case of biosimilars. About interchangeable biosimilars, as I said, it is biosimilar which has undergone a switch study as well and shown efficacy in this. So all insulins are biologics, no doubt about that. Many of them are biosimilars, but not all biosimilar insulins are of course interchangeable insulins. This is the map of biologics, global map of biologics. So the blue countries are where there are some regulations for marketing of biosimilars, and the red countries are where there are no such regulations. As we can see, India is blue, so there are some regulations before biosimilars can be marketed, but many of its neighboring countries do not have so much rules and regulations on that. So these are the biosimilar insulins that are available globally: biosimilar Glargine, biosimilar Lispro, and biosimilar Aspart. When it comes to South Asian countries, in India, apart from mixed-ard and regular, we have biosimilar Glargine, of course, many companies have come up with that, and one biosimilar Aspart. Biosimilar Lispro, to the best of my knowledge, is not available here, but if we look at Bangladesh, there are many more biosimilars that are available just because the regulation policies are not that strict. So biosimilar Glargine and innovator Glargine, of course, they have the same amino acid sequence, and biosimilar Glargine have a lot of evidences in type 2 diabetes in their favor from the element group of studies, from the InStride group of studies, all of which have shown they cause similar amount of HbA1c reduction, similar proportion of patients achieving target A1c, similar insulin doses, and almost similar rates of hypoglycemia. And there have been several meta-analyses as well showing the same things, that the HbA1c reduction and fasting glucose reduction between these two are at par. Of course, nowadays without CGM, we cannot call a molecule a good molecule. So again, we have CGM evidence also showing similar glycemic variability for biosimilar Glargine and the innovator Glargine. So coming back to my two cases, the 56-year-old shopkeeper whom I was planning to start insulin, he trusts the doctor, and so I started him on 10-unit biosimilar Glargine, and at 6 weeks, his glucose levels are pretty good. For the Google trusting patient, of course, he is already on basal bolus MSI, so before I go on to change anything, the first thing I need to do is, of course, to try to understand what is causing the uncontrolled hyperglycemia in this gentleman. As we know, medication adherence is one of the most important issues. The first thing we do for all patients inevitably is to check compliance, and just 1 point drop in medication adherence could increase all-cause mortality by 1.6 times, that's what data shows. And around 25% of the non-adherence is often due to cost-related issues. People just do not discontinue insulin, they do more dangerous things like rationing insulin, travel abroad to get it. So many patients from Bangladesh come to Kolkata for treatment. Time may come when people from Kolkata will go to Bangladesh to get biosimilar options because there are many more biosimilars available there. So for the second patient, on inquiry, it was revealed that he was actually rationing his glargine. He was reducing his glargine dose and taking more of his regular insulin because he thought that total daily dose remains same, so I can do that easily. And that is why he was having recurrent hypos, fasting was still high, as was his HbA1c. Now when I counseled this gentleman about, I told him about biosimilar glargine available, of course he had more questions to ask. Like, what is it different from generic? Can I just not take generic insulin? So biosimilars and generics, of course, both of them are apparently comparable to the reference molecule at a more affordable price, offer similar treatment benefits, almost similar side effect profile, and they are approved through an abbreviated pathway, bypassing the need for expensive clinical trials. But what are the differences? So generics can only be for small molecules, which are very stable. Biosimilars for large complex molecules like insulin, we need to have biosimilars only. The stability requires special treatment. The devices, generics are always oral. For injectable molecules, we need to have biosimilars, and that too, the devices can vary. Of course, the production is only chemical synthesis for generics. For biosimilars, it is very sophisticated biological process through which it has to undergo. And the developmental stages, more significant research is required for biosimilars. The regulatory pathways are more stringent, as well as is the post-marketing surveillance. So just for a pictorial idea, aspirin, a small molecule, it can have a generic. But insulin onwards, insulin, erythropoietin, the large monoclonal antibodies, the only thing that we can have for these molecules as a more affordable alternative to the innovator molecules is biosimilars or follow-on biologics. Now, since the biosimilars have to undergo so much of sophisticated biological recombinant procedures for manufacturing, there are many areas for potential variation as well due to differences in cell culture, the cell harvesting methods, the enzymes, and all of these. So the second case, I managed to counsel him to take biosimilar glargine and titrated his dose, and at 6 weeks, his HbA1c did reduce, but he was still not happy. He had multiple complaints like insulin side reaction, feeling giddy, blah, blah, and so many complaints, and he believes he was feeling better with his previous insulin regimen. So, yeah, there are many patient-based barriers to biosimilar use, which are mostly influenced by manufacturers' names, brand awareness, lack of proper knowledge about what biosimilars are, how they are approved, and something known as the nocebo effect. As we all know, nocebo is the opposite of placebo. So nocebo effect is the development of symptoms after switching from an innovator to a biosimilar products, which actually occurs in a significant proportion of patients and can be minimized through proper counseling alone. So, but of course, it's always, the final call has to be by the patient, not us. We cannot run after a patient and push insulin to them of our choice. And so, are the biosimilar insulins as safe as they are told? Are there no concerns at all? What about immunogenicity, potency, and new unknown adverse effects? Of course, in addition to the already known adverse effects of insulin, so all these concerns about immunogenicity mostly stemmed from the erythropoietin controversy. After biosimilar erythropoietin, there were so many cases of pure red cell aplasia, as we know. But later on, it was seen it was due to the additives, that is the polysorbate and the rubber plunger that was used, which caused this pure red cell aplasia. Also, for interferon beta biosimilar, again, the increased immunogenicity was due to different cell lines. As for biosimilar glargine, we do have some data, enough of data to show it's not additionally immunogenic as compared to the innovator insulin, and the antibody titer was much lower than the cutoff of 5% to call it actually triggers immunogenicity. So after appropriate counseling, when the second gentleman was counseled at 3 months, his HbA1c was very well controlled with biosimilar glargine and prandial regular insulin shots, and his total daily dose of insulin was actually reduced. What about this? A 15-year-old girl recently diagnosed type 1 diabetes, has affordability issues again, poorly controlled HbA1c. So truly speaking, do we need trials for biosimilar insulin type 1 separately from type 2? So if we go by rules, if a biosimilar is approved for one indication, approval is assumed to be granted for other indications as well. But this is not true for India. However, for biosimilar glargine, again, we have enough of data in type 1 as well from the InStride group of studies. And also for insulin Lispro, biosimilar Lispro, there is data in type 1 diabetes. For biosimilar Aspart as well, we have data in type 1 diabetes. So this girl, she was put on biosimilar glargine. Honestly speaking, if we are talking about biosimilar analog insulin, if somebody only affordability issue is the concern, I would rather put that person on regular insulin instead of rapid acting analogs, rather than switch them, rather than try a biosimilar analog insulin in them, if only cost is the concern. So anyway, this girl, she was put on biosimilar insulin and regular insulin boluses with well-controlled HbA1c. Coming to my final case, a 66-year-old man. He has recently retired, he does not drive any pension, and he still now was on innovator glargine along with oral medicines with a well-controlled HbA1c. He was taking glargine using vials and syringe. Now he wants a more affordable option as his earning will reduce, and he wants to discuss whether he can switch to biosimilar insulin, glargine insulin instead of innovator glargine. So talking about switching, the terms switching, interchanging, substitution are actually different technically. Switching, the decision is by the physician only. Interchanging, the decision is by the pharmacist, but only with after discussion with the physician, with the prescriber. And substitution is something that is done for the generics, in which the pharmacist can change without even consulting the prescriber. Now talking about biosimilar glargine, it is not available in vials, it is only available in pens. And if we look at the price of biosimilar insulin pens as compared to innovator insulin vials, the former is actually more than the innovator insulin vials. Biosimilar Lispro does come in vials as well as in pens, but I don't think it is available in India. And again, the different devices for the different biosimilar insulins are often different from not only from the innovator insulins, but they have different features. Some have dial-back features, some don't. Some have end-of-content features, some don't have that. Now this was an interesting study in which the authors had compared 3 biosimilar insulin, glargine insulin devices with the innovator insulin devices, and they found that the dose variability was higher, higher injection force was required in the biosimilar devices as compared to the innovator insulin pens, and there was no end of content feature. But again, this trial was sponsored by the innovator insulin molecule, so I would take it with a pinch of salt, of course. Repeated interchange, however, it has been shown if we are switching from biosimilar to innovator again to biosimilar like that, if we are doing, repeated interchange could trigger immunogenicity and compromise the efficacy and safety of both. And it is important that we do not switch during critical periods like pregnancy or planning conception, prior to a travel, serious illnesses, and somebody who has history of failure with other biosimilar agents, even if that is not a biosimilar insulin. So for this gentleman, after discussion, who was on innovator glargine and was using vials, and he was wanting to switch to biosimilar, but after explanation of everything and the costs, he preferred to continue his glargine insulin using vials. So take-home messages, biosimilar insulin, we do have a very good body of evidences supporting their efficacy as well as safety, but they are not generic insulin. They can be used in place of the innovator insulin in practically all indications, of course at a lesser price. The dose is the same, but the devices could be different. There is no additional concerns about adverse effects, but the switch should not be in critical periods and the switch should not be repeated, and it should always be a shared decision making. So as we know, good, fast and cheap, combination of all of these 3 is a utopia. But if we are talking about good and fast insulin, I would say it's the branded innovator insulin. If we are talking about fast and cheap insulin, it could be if there was some form of generic insulin or generic other molecules. Good and cheap would be a branded insulin only if it is given by the government hospital or covered by some sort of insurance. Biosimilar insulin, of course, is not the perfect utopia, but is close to something that is good and fast and cheap. Thank you so much for your kind patience hearing.
Thank you, Sunetra, for your wonderful overview of this particular topic, which is biosimilar and innovator insulin. We have been using both for quite long time. I think they are essentially similar as far as their efficacy is concerned, but little concern of mine is I've seen some of immunogenic reactions with some of the maybe batch by batch differentiation may be there. I do not know what is the experience of this August gathering, because we are now exposed to both as far as insulin is concerned, both biosimilar and originator, but we need to understand that with a lesser cost, maybe we are having a molecule which is efficacy-wise, as you said, is equipotent. But my only concern, as I said, is immunogenicity, and switching over from one to another may not be a very good idea. That's my understanding. And if from the floor, if you have any queries or questions or comments, you are free to make it here. Or if you don't have any query, oh yes.
There is one thing Sunetra has mentioned beautifully about the regulations. So I would like to say that in India, for a biosimilar to come to practice, it has to pass through 10 stages of biosimilarity. So one of the reasons is immunogenicity is checked there itself. So sometimes the switch may not be as deleterious as someone may think of. So to me, in these regulated countries like India, USA and all, the biosimilars which are actually passed, for sale or for use, I think they are pretty safe, and I think we should be happy with that. Yeah, that is my only point.
Yes, I support Orkojit, and in my opinion, it should be a shared decision-making process.
Yes.
That you showed in your slide that the patient opted for the branded one,
Yes.
but patient may opt for the biosimilar also, and maybe economically at an advantageous position. Then,
Yes.
thank you, Sunetra. The talk was good. Thank you.
So
Thank
if
you,
there
ma'am.
is no other questions, can I conclude the session? Thank you, Sunetra, once again for your wonderful overview. Thank you.
Thank you, Speaker, sir. I would request Chairperson, sir, to kindly felicitate Dr. Sunetra Mondal. Thank you, ma'am. Thank you, Chairperson, sir. With this,